Good day, good afternoon, good evening, good morning, dear friends. It's a great pleasure for me to chair this webinar with two eminent experts in sexual medicine, old friends actually. I'm sure that we will get a lot of very important information useful for our everyday work. So without losing any time, because we will fill it, we want to fill it with the good talks and presentations, I would like to introduce the first speaker, Dr. Michael Krychman, and he will talk to us about approach to sexual dysfunction. Michael is the executive director of the Southern California Center for Sexual Health and Survivorship Medicine, located in New York Beach, California. He is the former co-director of the Sexual Medicine and Rehabilitation Program at Memorial Sloan Kettering Cancer. Dr. Krychman is also an IE-SECT certified sexual counselor and an AA-SECT certified sexual counselor supervisor. He's a clinical health professor at the University of California, Irvine, Division of Gynecological Oncology, and the medical director of ANS Clinic, a high-risk program for breast and ovarian cancer survivors. So please, Michael, the floor is yours.
Well, it is a great pleasure to be here, and I'd like to thank the IMS for inviting me to talk to you this morning about this very important and very timely topic. So we'll jump right in, and I hope in the next 15-20 minutes I'll leave you with some practical implementations and some clinical pearls that you can implement in your clinical office almost immediately. I want to put this disclaimer that I typically will discuss sexual health from a cis female and male perspective using gender terms and pronouns due to convention. However, sexual health needs for all genders are important and relevant, and we need to take into consideration the language and the forms that we have in our clinical practice to be very inclusive and make everybody feel welcome, and that their sexuality and their sexuality needs are very important in the overall care. I like to divide cancer care into three phases. One is echo, then TAF, then survivorship. Echo is when you are actually told that you have cancer and you're kind of in a state of shock. TASK is when you are going through your surgery, radiation, chemotherapy. And then people will say you're in survivorship, and survivorship really is about wellness and prevention, and that's where we're going to focus. Many people believe that wellness and prevention start at the diagnosis, that you can begin to treat some of the after effects of cancer care as you are trying to get disease under control. And very often cancer is looked upon as a chronic medical condition that is manageable, and we have to prevent recurrence and optimize wellness no matter what stage of cancer treatment you are at. It is almost estimated that almost every single cancer survivor, no matter what stage, no matter what grade, no matter what cancer, will have some impact on their overall quality of life, and this may impact sexual function. We'll try to give you some overarching concepts that will help you no matter what cancer, whether it's gynecological or breast or other issues, and some framework for which you can think about these changes. But we can see here that almost 100% of cancer patients will have some impact on their overall sexual functioning and what have you. I like to divide it up into these facets, that there are really physical limitations, there is pain, there are psychological ramifications for getting this chronic diagnosis, then there is medications and treatment side effects, and sometimes we are on medications for quite some time. We know that the average person will have at least 4 chronic medications. There are partner relationships going into a diagnosis, and the diagnosis may actually compound those factors in terms of a partner, as well as the physiological issues. And these are all very impactful in the overall paradigm of how we look at, and how Dr. Kingsberg will talk about how sexual health is assessed and discussed. Again, another way to divide up the impact of cancer and cancer care on sexual dysfunction is really the direct effects. How is it affecting the vascular issues, the neurological, the veins, arteries, nerves, the psychological issues, and what anatomical damage has the cancer done directly or what we have done through surgery? Indirect really is about some of the treatments, whether or not we have issues related to tremor, fatigue, pain, anxiety, and again, iatrogenic, things that we are doing, medications, radiation, surgery, chemotherapy as well. And remember, all disease happens in the context of a psychosocial setting, which would include what is going on in the family, with work as well. And these are also added pressures that a person who is diagnosed with a gynecological cancer will have to address. So again, we talked about the anatomical surgery issues, and those are really divided into therapeutic, what we're doing, plus prophylactic. We are taking out another ovary, we are taking out a uterus, we are doing things in terms of genetic predisposition and trying to prevent surgery, prevent a cancer, and these all have far-reaching implications. We'll talk a little bit about chemotherapy and radiation, as well as the maintenance therapy. Sometimes people are on medications, cytostatic medications, things that can be quite impactful into the overall sexual response, whether it will affect desire, arousal, orgasm, or what have you. So radiation, again, this slide is quite detailed, but we'll just highlight some of the things. After radiation, you may have changes in sensation, you may have discoloration, thickening of the skin, fibrosis. We know that external beam radiation may cause vaginal agglutination, foreshortening of the vagina, difficulties in range in motion. Also, alopecia may be a problem as well. And again, these things need to be taken into consideration, and we may need to implement a variety of different therapeutics in order to combat some of the immediate, chronic, and acute issues that radiation may pose. In terms of chemotherapy, I think the biggest issue to address is this chemically induced menopause and how premature menopause can not only affect the vaginal tissues and cause severe GSM, but also have issues related to quality of life, whether it's premature menopause, changes in the sexual response in terms of arousal, orgasm, and what have you. We know that there's neurological changes. There are things like brain fog. There are things like fatigue as well as mucositis that can be quite impactful. Hormonal levels decline with extended and prolonged chemotherapy. Very often patients are kept on chemotherapy long-term, and this will have a direct impact on libido, arousal, orgasm, and ultimately lead to dyspareunia. So again, some of the important facets to remember in terms of chemotherapy-induced menopause is very often these are younger women, and they are having very severe symptomatology. The important concept in a gynecological cancer issue is that there are many downstream issues from chemically induced menopause, changes in sleep and fatigue and memory changes, as well as changes in the sexual function response. And we need to take this all into consideration, whether it is a direct effect from the chemotherapy and the agents that are being used, or as a result, or in combination with the loss of ovarian function due to the chemically induced menopause. So very important to look at these, the symptomatology of menopause during this transition. There are also very detailed concerns, whether it is fatigue, pain, range of motion, shortness of breath, sometimes the issues related to ostomies. There's also pre-existing issues. And again, we need to take into consideration the patient, the context in which their life is occurring. There are special concerns regarding ageism, special concerns regarding those who are involved in same-sex relationships, as well as pre-existing disease before the diagnosis of gynecological cancer. We also know that for palliative care, this has really been a long issue that has been very often neglected in cancer care. And we were instrumental in developing a palliative care and intimacy program at many of the institutions that I worked at. And very often it is very important to remain that human aspect and importance for touch. So even if someone has severely advanced disease or recurrent disease, optimizing quality of life, optimizing the intimacy and issues related to humanness are very, very important. And we shouldn't preclude discussing intimacy or sexual touch, even in the face of a very chronic condition or a very advanced stage of cancer care. I think the concern about recurrence also very important, and very often this is highly prevalent. And we talk about survivorship is about optimizing wellness, which includes menopausal management and includes the concept of sleep and bone health as well, but also prevention and how we can help have a high level of clinical suspicion for issues related to cancer and how they may return as well. I'm going to just highlight a few things with each of the gynecological cancers, and again, recognize that you can give a 60-minute lecture on each of these and answer survivorship. So ovarian cancer, typically diagnosed at an advanced stage, they undergo typically a surgical debulk, which includes abdominal hysterectomy, ovarian removal, and debulking procedure. The important issue is menopausal syndrome can be severe and needs to be addressed because that can really be impactful and really have an impact on quality of life. We need to also look at those who are genetically predisposed to BRCA1 and 2, and those are many patients who I see who are opting for risk-reducing surgery. They have bilateral mastectomies, they have ovarian removal, and they also will experience severe and often debilitating menopausal syndrome. And again, I think it's quite important to look at these patients. Those that do not have cancer certainly can be optimized with a whole variety of treatments, and many of them may choose hormonal therapy, and the literature does support that these patients can be on this. I tend to want to incorporate the entire team as well. Endometrial cancer, again, remember the uterus is removed. Sometimes it's a partial vaginectomy as well, which may lead to smaller vaginal issues, and there may be some concerns about penetration. You may have foreshortening, you may have radiation changes, changes in epithelium. And again, looking at GSM is a very, very important concept, and having aggressive vaginal rehabilitation also quite essential. So maintaining adequate lubrication. Cervical cancer, we tend to see a lot of cervical cancer at my institution. And again, these patients are undergoing radical hysterectomies. They're getting adjunctive radiation chemotherapy, very often have loss of ovarian function with severe ovarian failure and severe debilitating menopausal syndrome as well. Vulvar cancer very often can present with radical vulvectomies with complications from surgery, including numbness, incontinence, and range of motion. We know that there are radiation and chemotherapy being used in the treatment paradigm, and there's risk of scarring, changes in function as well, and issues related to vaginal obliteration. Sometimes even the clitoris will be removed, and that may impact the vaginal opening as well as arousal and orgasm capacity. So again, these surgeries can be quite extensive, and they may need a multimodal treatment paradigm. And again, we're talking about pelvic exents where they're having the vagina, uterus, ovaries, bladder, urethra, rectum, and anus are removed. Very often we are seeing these patients in sexual medicine prior to this large surgery to not only help them on a physical level for rehabilitation, but understanding that they may have two ostomies, one for urine, one for stool, and these surgeries can be quite extensive and quite challenging from both a physiological and psychological perspective as well. Let's turn gears and talk for the last several minutes about treatment. And I think this is a multimodal concept where you have your oncology or primary care team, the patient and their family and support system, as well as sexual medicine and or gynecological care, as well as the menopause specialists. I think we need to focus on rehabilitation, not necessarily treatment. And I think the concept is that once you get a diagnosis of cancer, things are never going to return to the way they were before, but they can be optimized. So we talk about the new normal or the new good normal, because I think once you get that diagnosis, your life is forever changed. You are always going to be a cancer survivor living with a cancer diagnosis and have some concerns. Important facet to remember is we all go into the diagnosis of cancer with some pre-existing issues that impact sexual function, age, boredom, relationship issues, communication, which Dr. Kingsberg will talk about. We may be on medications for chronic issues. Very often we have a lot of women on thyroid medication or antidepressant medications prior to the diagnosis of cancer. So you're setting the foundation to have superimposed issues on cancer. So again, understand that we need to look at the person in totality, not only looking at the cancer and the impact, but also, is there underlying cardiovascular disease? Is there endocrine issues? Are there pre-existing psychiatric issues as well? So I think it's important to recognize cancer is impactful, but there are other facets that are implied. There are several sexual accessories that are specific for sexual health and optimizing function, not only for gynecological issues, but things like ostomies and ostomy bag covers and pellets you can put in the ostomies to help against prevention of odor. There's implants, special clothing. There are products to improve sexual self-esteem, like things that some women may want to do or use to help them feel more feminine. I think it's important to talk about collision dyspareunia, and again, we can talk extensively on this. This is really about a foreshortened vagina, kind of lock and key issue where women are complaining that the vagina is too short and they may have pain. There are external devices that are available worldwide, whether it's the ONET device, the Come Close device, that these will allow penetration but limit the depth. We also counsel people on sexual positioning, and a first and foremost primary entry into treatment of arousal or lack of lubrication is the use of non-hormonal over-the-counter vaginal moisturizers and lubricants. And very often, I always like to say that there are some concerns about herbs and supplements. Cancer patients tend to overutilize these, and we need to be consciously aware that we need to follow the evidence. There's not always good evidence. Look to the IMS, look to Menopause Society on position statements where the evidence lies, and recommend that. A good referral place that I recommend is aboutherbs.com. It is from the Integrative Medicine Center at Memorial Sloan Kettering, where they provide all the evidence, all the articles, and you can look up the herb and or supplement and really get an evidence-based approach. I always tell patients, bring in what herbs and supplements you're taking, because very often there's a fine print and we need to be quite careful about what our patients are taking. There are a whole variety of sexual accessories, and again, that are designed specifically for patients who have limited mobility or changes in function, as well as discussion of sexual positioning, limiting the issues related to depth and force of penetration. So counseling becomes quite important as well. I won't get into this to quite depth, but using psychoeducational treatments, including cognitive behavioral therapy, or even other kinds of therapy, which Dr. Kingsberg will discuss. Mindfulness as well as relationship exercises are also an integrated part of the overall treatment paradigm for a cancer patient who is adapting to sexual health issues and concerns. I would say that we need to look at sexual pharmacology in a new light. Hormones are typically underutilized in cancer patients. I think that many cancers are not hormonally sensitive, and patients are not informed adequately. So again, collaborating with the oncologist and seeing whether or not hormones are a viable alternative is something to consider. And I think we need to readdress these issues. In terms of management of hot flashes, we have many things in our war chest. And again, I would recommend following the evidence and really looking at a whole variety of different things that we can use. They're listed here, not only hormones, but antihypertensives, clonidine, the SSRIs, gabapentin, venlafaxine. We know that Veozah is the new kid on the block and has really been quite remarkable in terms of impact on cancer patients who have been suffering from severe debilitating hot flashes and sleep issues. And this should also be in your war chest. We also know that patients may not want medications. And again, although there are a whole lot of things that are recommended, and many of them are listed here, if you look at the Menopause Society and IMS, my advice is to follow these guidelines, recommend things, monitor your patients, and again, look at the evidence for which they are doing. And again, I guess the first thing in medicine is do no harm. So if the patient says she's using a menopausal sheets and PJs and it's helping her, I do not go into a whole discussion about the lack of evidence. I really want to support her in her decision making, and that if she's empowered and taking decisions and doing this. But again, if I'm recommending, I want to make sure that I'm following the evidence as well. We can't underestimate the importance of dilators, and an aggressive vaginal rehabilitation program is paramount, coupled with pelvic floor physical therapy ongoing. So revive and restore and replenish the vaginal tissue, either with moisturizers and lubricants or minimally absorbed local vaginal hormonal products, and then use of intravaginal Valium. And again, an aggressive program to me means frequent and recurrent visits. This has been shown to help improve compliance, adherence, as well as moving the patient towards sexual recovery. I think this is an excellent slide. It shows that there's a multimodal treatment, and it's not really sequential. It's really more like the sun. There are multiple areas where you can effectively treat sexual function in those who have a gynecological cancer, treat these systemic illnesses, look at the medications and how they're impacting the sexual function, look at what the partner is doing and how we can educate them to be supportive, and the partner themselves may have sexual problems. Evaluation and treat with pain. You may need pre-medication or planned sexual activity when pain is at its minimum. Be liberal in our ability to refer for psychotherapy and incorporate our mental health professionals. It is a team approach, and we very often need multiple providers, whether it's pelvic floor physical therapy, our mental health professionals to help. Be liberal in sexual pharmacology and understand that there are multiple ways that we can treat and impact the underlying issues, whether it's simple things like hormonal therapy, systemic and or local therapy, very important. Sexual devices can be very important as well. And also don't minimize the issues related to behavioral modification or alternative concepts, and be an open mind. So very often it's a piecemeal, and you can use multiple areas of intervention in a patient. I tend to do what's called a layered approach, where we do one or two interventions at a time. and bring them back and see what's working and not. I don't do the cluster, which means you give them everything and then see what sticks. I think it's very important to layer the effect. Very often they're dealing with a lot of trauma, and slow and steady wins the race with frequent visits will help people recover in terms of sexual functioning. What's underutilized? Hormones, physical therapy, dilators, intravaginal Valium, definitely understand that there's sexual appliances, and use behavioral techniques, pillows, pre-medicate with pain medication, incorporate your mental health professionals, and use your sexual pharmacology that is available in your area as well, and really look at the totality of interventions that we can use and optimize functioning for our gynecological patients. There are some official recommendations, and I'm not going to go over them in detail, but again, you can review these on your own. We talk a little bit about some of the side effects, and again, liberal use of vaginal dilators, local vaginal estrogen, incorporate a team effect and speak with your oncologist. I always say speak with the oncologist, don't text them or email them. Sometimes we need to change the view of our oncology colleagues one at a time to understand that women are suffering and suffering in silence, and we need to be aware of the most current literature. I think it's important to use psychoeducational programs and mindfulness as well. A word of caution that our patients are seeing media healthcare professionals, which are professional media personalities, versus those of us who are in healthcare who does a little bit of media. And very often they're coming into the office with a lot of misinformation. They want salivary hormone testing. They want a whole lot of other interventions that are not evidence-based. So I think it's very important to follow the evidence and help educate our patients as well as to what is safe and what is questionable and what needs further elucidation, whether or not it's safe in gynecological patients. I think this is an excellent, most current article for managing menopause after cancer care. It was in the Lancet just recently in 2024. It was one of the series of 4, and it really talked about the importance of looking at the overall experience of menopause after a diagnosis of cancer, whether it's gynecological or breast or what have you. So I think this is a great reference article to look at. And really talks about a lot of the things that we have talked about in generalization. It also talks about the concept of understanding that the menopause transition for some women is not pathological and they're not suffering, and we should also weigh this against aggressive intervention. We need to look at sleep, mood, quality of life, menopause, and the impact that it is having on our patients as well. It is a comprehensive team, and I think referral is never a failure. Incorporate a team, and you may need a whole variety of professionals to help you manage your menopausal patient who has a gynecological malignancy, and be aware of those in your community who are interested in being advocates for cancer survivors as well. And I'll finish with this. I say we have 2 ears and 1 mouth. I think it's very important to listen twice as much as we speak and ask. You can't treat a problem if you don't know that one exists. So I think that is a very critical facet in terms of the overall management. Very often we talk too much, but we need to listen to our patients, see what is going on, almost be a menopause sexual medicine detective, and really look at a multimodal approach to the management of gynecological cancers and their impact on sexual function. Thank you so much. And with this, I will conclude. Here are some additional references. And again, we'll be happy to answer questions after Dr. Kingsberg. Thank you so much.
Thank you so much, Michael, for this comprehensive and very well evidence-based overview over oncosexology on a whole. Thanks a lot. As we have mentioned before, and as you mentioned, please, participants, write down the questions you have. We are going to discuss it at the end. And now I would like to introduce the next speaker, which is also very known to you, probably, Dr. Sheryl Kingsberg. She is the chief of the Division of Behavioral Medicine at McDonald's Women's Hospital, University Hospitals Cleveland Medical Center, and professor in reproductive biology, urology, and psychiatry at Case Western Reserve Universities. Her areas of clinical specialization include female sexual disorders, menopause, pregnancy, and postpartum mood disorders, and psychological aspects of infertility. Sheryl will talk to us in a very practical way, which is frequently not so easy for most clinicians, namely how to talk sex with cancer patients. Thank you very much, Sheryl. The floor is yours.
Well, thank you, Professor Bitzer, and it is certainly an honor to present with my esteemed colleagues, Dr. Krychman and Professor Bitzer. They are indeed not old, but long-standing friends.
Not old. Yeah.
And I have to say that I really appreciate the IMS choosing this really critically important topic. We certainly don't talk about sex enough, particularly sexuality and cancer. And I have always admired the IMS for covering this topic. So thank you for inviting me. I'm going to share my screen. Let's see. So I have to say that it is always a struggle to follow Dr. Krychman. His talk was truly amazing and so comprehensive. And so I want to take you back a little bit to more of a 30,000-foot view because he gave you the details about what the concerns are for women with a variety of cancers, and to his comment about terminology. While I also use the term female or women, I acknowledge that that can include a variety of people and individuals. So I do have some disclosures and a couple of learning objectives. I really wanted to identify the common problems in women who are being treated for or survivors of cancer. And Dr. Krychman nicely talked about the echo and task phase and then survivorship. So that includes all of those areas. And then describe screening and assessment of sexual concerns in these women and actually, frankly, in all women. So let's just ask the $64 million question. Why in heck would we open Pandora's box and ask about sexual concerns? With any women, particularly women struggling with either cancer diagnosis, treatment, or survivorship? Well, the simple answer is there is an incredibly high prevalence of sexual problems and concerns in these women. And secondly, sexuality is important to quality of life for all of us. Think about how important sexuality is to your own life, and then sort of try to put that on your patients and recognize it is hugely important. And what we often don't recognize, particularly with women, as Dr. Krychman talked about, once you have a diagnosis of cancer, that is part of your identity forever. But the impact of the healthcare professional asking a woman who has or survived cancer has a huge psychological benefit. It makes them recognize that they are not just a patient. They're not just a cancer patient. They are now a fully functioning woman who deserves to be able to have healthy sexual function. And it really does improve their perception of their right to be sexual simply by the healthcare professional asking. If you ask, they say, wow, my healthcare professional thinks I am entitled to think about my sexuality. And that really, if that's all you did, as Dr. Krychman said, just ask. If all you did was ask about that, that can change their self-perception. We know from data that the overwhelming majority of patients retrospectively report that they wish they had been told before treatment, so in that echo phase, how it might impact sexual function. We often don't address that. Just, you've got a diagnosis, we got to get you into treatment, and nobody really has that discussion about, well, you need to know what really might happen to your sexual function. We do also know that inquiring, simply asking, does serve as an intervention. It has people and women much more aware of what they should be thinking about, whether they have symptoms. And so inquiry is an intervention into itself. And just for your own quality of life, assessing sexual function improves patient satisfaction with their healthcare professionals. So it makes you the hero already. Okay. So let's take a step back and just briefly, because I don't want to spend a lot of time, because I'm hoping that I'm preaching to the choir here, that let's talk about what sexual function is before we think about how we're going to ask about it. So there are a variety of models to understand the sexual response in all genders, but looking back historically, we can start with Masters and Johnson, who are really the first to empirically study the sexual response in males and females, bringing people into their lab, and based on their sort of physiologic research, looking at how people responded to a sexual encounter or self-stimulation in the lab, they said there's a linear progression of the sexual response. That first you start with excitement, which is essentially being aroused by some erotic stimulation, whether visual or physical, and that with that, for females, there is going to be vaginal lubrication, engorgement of the vulva and the genitals. There's an increased heart rate. There's increased temperature. There's nipple erection. And that is the excitement phase. With enough appropriate sexual stimulation, the body reaches a peak level of excitement called plateau. And then with enough stimulation, we hope the body can then trigger an orgasm, which is simply the release of all that sexual stimulation, reflexively experienced in sort of contractions every 0.8 seconds. And then the body eventually moves to an unstimulated state called resolution. Right? And so this model here, this graph shows that for females, there's an infinite variety of ways in which that sexual response occurs. And so although they talk about a universal experience of this linear progression, it's important for you to recognize that within a woman or between women, there can be an infinite variety of the ways in which she experiences the sexual encounter and that response. So some women may be easily orgasmic, some women may never reach orgasm, and we would consider them to have an orgasmic dysfunction. Some women may have their response vary either over their menstrual cycle or from pre to post menopause, or based on whether they're self-stimulating or with a partner or which partner. So there's an infinite variety, and women are going to come in and ask you, if they can get up the nerve to ask, what is normal? What should I expect? And that's important for you to feel comfortable being able to answer that question. Now, in the 1990s, Rosemary Basson gave us another alternative model of the sexual response that was less sort of universal and similar, and it's not so linear. So as you can see, it's a circular model that really reflects the fact that women, particularly women as they're aging, or women in long-term relationships, or maybe women after they've had some treatment for cancer, may not have that spontaneous sexual desire that Masters and Johnson were talking about in that excitement phase. And Helen Singer Kaplan in the 1970s reminded us that the most important sexual organ is actually the brain, and that we should not forget to include desire, which is wanting for a sexual encounter, but for many women, that initial wanting may not be present so much, and that women will still choose to be sexual for a variety of other reasons. For example, emotional intimacy, or to remind themselves that they are surviving, or because they know it'll please their partner. So, or they heard it burns 500 calories to have a nice sexual encounter. So there's a number of reasons why women will engage in that sexual encounter, but they start with a position of neutrality. They're not really turned on yet. So they will engage, and it's very important to validate and normalize for women that arousal may take some time. They're busy doing the grocery list, or they're thinking, should I be having sex? And so they need some time to engage in stimulation before arousal kicks in. And once there's arousal, and by the way, there's an interference with, if there's pain or a knock on the door, that can sort of stop that cycle in its tracks. But with no pain and with appropriate stimulation, the body gets aroused, and it's only then that desire kicks in. And we call that responsive desire, and that sort of drives the cycle. So many women will need that validation from you that spontaneous desire that they had in the early stages of their relationship may not be there as often. They don't really, sort of swoon at the mere sight of their partner anymore. But that once they get started, the desire kicks in, and that is considered normal. If they never get that desire, then we have a desire problem. But please reassure women that it may be that they have more responsive desire. And Dr. Krychman talked about sort of an integrative approach, but the term that we really want to focus on is biopsychosocial. We really want to consider that sexuality is best understood from a biopsychosocial perspective, and that these factors often overlap, and that for you to do an assessment, keeping these factors in mind as separate first, and then recognizing that many factors might contribute, but it allows you to think about which components are impacted when you're thinking about, well, what do I want to do to help my patient in front of me? So there certainly are biologic factors, and with oncology patients, well, that's no surprise. So general physical health can impair sexual function, just like good physical health can improve sexual function. We know that endocrine changes, hormonal changes with cancer and cancer treatments can impact sexual function. Neurochemistry absolutely impacts sexual function, thinking about dopamine and serotonin levels. Psychological factors, depression, anxiety, body image, fear of mortality, all of those things can negatively impact sexual function. Religious and cultural beliefs in our sociocultural sort of grouping makes a difference. And interpersonal factors. The quality of a person's relationship, if she is in one, can certainly impact her sexual function. Either she has a partner that doesn't know how to approach her now, or she doesn't particularly like her partner, or there's poor communication, particularly after cancer and cancer treatments. Couples often struggle with figuring out how to communicate again. That all of those factors really can contribute to sexual concerns, and asking about each of those components can help you identify which your patient may be struggling with. So in general, there are about 4 categories of sexual problems to consider, and I'm not going to go into detail, just want to reflect those general categories. We have decreased sexual desire. The terminology would be hypoactive sexual desire disorder. There can be diminished arousal, and that's either cognitive, which is your sort of experience of sexual pleasure as you're engaged in sexual activity, or the ability to feel sexual sensation in your genitals. Orgasmic dysfunction, which would be defined as either the inability or reduced ability to reach orgasm, or decreased intensity. I think Dr. Krychman has often said that decrease in intensity may be sort of like going from a thunderstorm to the pitter-patter of a little drizzle. And finally, genital pain with sexual activity. And in the case of women after cancer treatments, particularly GYN or breast cancer, you may experience genitourinary syndrome of menopause. So I cannot overstate the impact of sexual problems that impact well beyond the bedroom. So please consider how important sexuality is. We know, for example, that low sexual desire negatively impacts many aspects of a woman's self-image and her relationships. In this survey I did several years ago, looking at women who had low desire, 69% said that it negatively impacted their body image, right? And so now if you think adding that to a woman who now has had cancer treatments that may have physically altered her, plus low desire, the impact on her sense of self beyond the bedroom is huge. 51% said their self-confidence, not just in the bedroom, but in general, was reduced by low desire. 67% said they felt less connected to their partners. 35% said that it negatively impacted their communication with their partners, and 35% were worried that their partner was going to cheat. So giving my message again about the importance of sexuality, what we know from Barry McCarthy, a clinical psychologist, is that when sex is good, it's good. It maybe adds some added value to a relationship, maybe 15 to 20%. But more importantly, when sex is bad or non-existent, it is hugely impactful on a relationship, draining the relationship of positive value, more like 50 to 70%. So please keep that in mind, that women are losing so many things when they're struggling with cancer, and losing the connection with their partner does not need to be one of them, right? So good sex is nice, but bad sex is hugely impactful. So Dr. Krychman went into such detail. I really don't want to spend much time on the examples here, but just to keep in mind how a variety of cancers and cancer treatments can impact sexual function. If you're thinking about allogeneic bone marrow transplant, we have graft versus host disease that can create genital burning, dryness, itching, hypersensitivity. If you have breast cancer and breast surgeries, either with or without reconstruction, you often may experience altered or loss of nipple or breast sensation, which for some women is hugely impactful. That nipple sensitivity was really important to their sexuality. Pelvic radiation, I don't know, let me count the ways in which it can impact sexual function. Vaginal stenosis, shortening of the vaginal canal, atrophy, dryness, thinning of tissues, all that will lead to pain, and sometimes vaginismus, which is the involuntary tightening of those pelvic floor muscles, making wanted penetration, if they engage in penetrative sex, impossible. Adjuvant hormonal treatments, the aromatase inhibitors, often have sexual side effects, including genitourinary syndrome of menopause, and we know that that can often lead to non-adherence because women are required to take these for years. Colon and bladder surgeries. Not surprising, it can cause incontinence, and not surprising, if you have either urinary or fecal incontinence, you're going to create a likelihood of avoidance of sexual activities. And in general, any and all cancers and cancer treatments can result in a loss of desire, arousal problems, orgasm problems, impaired body image, and impaired communication with their partners. There are many factors that can contribute to suboptimal sexual health. Believe it or not, 2024, we still have social stigma, and there is an avoidance of conversations in your office about sexuality. Women are often apprehensive to discuss sex and sexual health with their healthcare professionals, particularly women who are feeling they're ungrateful if they want to talk about that with cancer. And healthcare professionals often forego initiating conversations on sexual health for a variety of reasons, which we'll talk about. Many women, particularly midlife women, are not aware of sexual health concerns and conditions. They don't know anything about genitourinary syndrome of menopause, even though they know about hot flashes and night sweats. Many healthcare professionals are not aware of available treatments, and women are not, and have misperceptions. For example, Dr. Krychman talked about hormone therapy and how important it may be, and how many women who don't have hormone-sensitive cancers are still afraid of thinking about anything hormonal. Unfortunately, in 2024, there's still limited clinician training. And sometimes these treatments that are available are very cost prohibitive. They're not on regular formularies. You need prior auths, and so it's often difficult to get them. So why should we not assume that patients are going to bring it up if they do have a sexual concern? They're afraid that they're going to make you uncomfortable. Don't prove them right. Patients worry that sexual problems wouldn't be perceived as valid concerns. They're thinking about their survival. Only 34% of women in general with a distressing sexual function will ever seek professional care, and nearly 80% of healthcare professional patient interactions about sexuality are going to be patient initiated. So they're afraid to bring it up, and the majority are required to be the ones bringing it up. It doesn't happen enough. So when should you screen for sexual problems? Prior to treatment? Yes. During treatment? Yes. And after treatment? In their survivorship? Yes. Anytime and all times would be the best. What should you do? Well, please get comfortable talking about sexuality. You got to use good body posture. Do not stand at the door on your way out to say, oh, by the way, any concerns about sex? You don't have them, do you? You sit down, have an open conversation, and choose language that's appropriate to their age and ethnicity and culture. And if you have to, practice using sexual terminology. Always use open-ended questions if you can. We know that healthcare professionals tend to kind of bombard women with yes/no questions. That is hard on you, it's hard on the patients. But if you ask an open-ended question, women don't take forever. They will answer your question in less than 60 seconds. And what we know is that asking an open-ended question actually improves your ability to assess their functional impairment. It improves adherence to whatever treatments you and your patient decide on, and it improves patient satisfaction. So again, win-win. What are you going to use to screen? As Dr. Krychman said, just ask. That's all I can do is say, just ask, no matter how you ask. But if you are going to ask, please try maybe to use a ubiquity statement. It sort of validates and normalizes for women. So most women after surgery, after chemotherapy, after radiation, on an AI, will have sexual concerns or problems. What concerns do you have? Opens that door. Then you can do a basic assessment of their sexual function. Please don't assume that there is a lack of interest in one's sexual health based on their age. We know that women want to be sexually active and healthy well into their 80s and 90s. Their relationship status, oh, they're single, they don't need to think about it, or their health status based on their diagnosis. Rick Stavosky has said, you can normalize and universalize conversations. I ask all my patients about their sexual concerns. And again, use that ubiquity style question. You can follow up with yes/no questions about desire, arousal, orgasm, pain, but then follow that with, tell me about it. Sharon Bober and colleagues have a really nice screener that does all the work for you. It's a sexual symptom checklist. It's in the public domain. You can easily get it, or you can ask me for it. I'll get it for you. And it really addresses all the sexual problems that might be occurring. Are you satisfied with your sexual function? If they are, then you're fine. If you have concerns, then you can then find out about interest in sex, sensation, lubrication, difficulty with orgasm, pain. So you get all of those categories in case you forget. Jack Annan, many, many years in the 70s, developed the PLICIT model, I think for healthcare professionals to feel, where's their level of comfort in addressing sexual concerns. I've updated it to call it the POSIT model, but really it starts with, look, permission. If all you do is ask about sexual concerns and give women permission to be sexual, you have been great. If at the next level you can give some basic information, education about genital anatomy, side effects of medicines, resources that Dr. Krychman already provided you, you have already done them a great service. You can then give them specific suggestions using lubricants, using a moisturizer, using vaginal hormone therapy, or altering positions. Dr. Krychman gave you a whole host of different tools and ideas for women after having some difficulties with sexual function. And then at any point, refer them. If all you do is say, this is really important and I have colleagues who specialize, you can refer them to pelvic floor physical therapy or to psychotherapy, or to people who will give them more pharmacologic options. And so in conclusion, sexual health is important to quality of life in all cancer survivors. The clinician really should be the one to initiate discussion. And please, please ask open-ended questions, but at the bottom line, just ask, because as Dr. Krychman said, you can't treat a problem if you don't know it occurs. And trust me, most women with cancer and survivorship will have sexual concerns and questions. So I thank you very much. I'm going to stop sharing my screen.
Sheryl, thank you very, very much for putting now oncosexology into practice and helping us to translate all the information we got from Michael into our everyday work. I fully agree that there is a lack of training in almost everybody working in oncology to address the issue of sexual health. But I think you have shown that it is not difficult. It's actually easily learnable, and that we should really be encouraged to do it. Now, I have several questions on my sheet here. They refer to the first part. And if I may start, in case of a young breast cancer patient, estrogen positive, that has her own natural cycle, can we propose transdermal or vaginal estradiol for GSM and menopause complaints? I think that would be for Michael. Would you? Did you hear me?
Yes.
Yeah.
So typically, there is actually a nice position statement, comprehensive article on breast cancer and GSM, and that is through the Menopause Society, as well as there is one from the American Congress of OBGYN. There has been traditionally some thought that minimally absorbed local vaginal estrogen, ultra low dose, can certainly be used. Very often you have some concerns. There has been some recent articles, I believe, published out of the Netherlands that have shown that the low dose vaginal products in those that are on aromatase inhibitors may be associated with an increased recurrence. So traditionally, we've been using local estradiol or estriol or ultra low dose to reverse and restore the issues related to GSM. A more conservative approach that we have kind of transitioned to is the liberal use of moisturizers, lubricants, topical lidocaine, as well as really reassessing and reevaluating the pelvic floor. Very often they have pelvic floor hypertonus. They may need intravaginal Valium, pelvic floor physical therapy. Let's also not forget that once we can get people back to resuming sexual intimacy, this in itself may be helpful as well. Where we have moved and transitioned is really intravaginal DHEA. And if you look at the product insert, breast cancer is not a contraindication. It is really considered a relative contraindication, a warning and precaution. So again, I think this discussion of minimally absorbed local vaginal estrogen, really you need to look at where the patient is. So if you're saying somebody is cycling, they certainly have some estradiol already in their system. And they are not being suppressed externally. They're not in chemical menopause. So again, I would use a collaborative approach. I tend to be much more conservative. I start conservatively aggressive, which I will try, a good vaginal moisturizer, maybe incorporating a dilator program, pelvic floor physical therapy, and then transitioning more towards intravaginal DHEA. Or we, in the US, because it is not approved, we very often will will compound estriol. I know there is some data from Cano et al. That showed that ultra low dose estriol, which is a very weak estrogen, can certainly be used. It's interesting, some of the oncologists will advocate for intravaginal testosterone, compounded intravaginal testosterone, because the patient may be on an aromatase inhibitor. So again, you have to look at the cancer, the grade, the stage, the age, the status, and the severity, as well as try to quantify and assess where the patient is in terms of their risk and their cancer journey as well.
Thank you. The next question is about the vaginal volume. One participant asked, what is the dose of vaginal volume? And can you comment on the dosing and frequency of intravaginal volume? That seems yeah.
So what I do personally, I think you can use a whole variety of doses, 5, 10, or 20 milligrams. I compound that into a vaginal suppository. And again, you want to assess the severity of pelvic floor hypertonus, the severity of levator ani spasm, and really look at the concept. I tend to do a 90-day treatment. So it is QHS for 30 days, 3 times a week for 30 days, twice a week for 30 days. And I assess the patients on a monthly basis, as well as you want to get them into a comprehensive pelvic floor physical therapy program and or use a dilator program. So what I would like to just preface say is I really appreciate the pelvic floor therapists and their commitment, but for some women, it is very, very challenging. It is a huge time commitment out of their day. You know, they have to leave work and or arrange childcare. It is an extensive commitment to drive there, get undressed, get pelvic floor physical therapy, redress, get back home, get back to work, what have you. So we do a dilator program in office that a patient can implement the exercises at home at their convenience as well. So intravaginal volume shouldn't be used in isolation. It should be used in tandem with other issues. And it really depends on the extent. So I typically start at 5 milligrams. I'm very conservative, as you might have guessed. I also say for patients to try it on the weekend, in the evening, because it is going in the vagina. There may be some minimal absorption. We want to know how they're responding the following day. And again, use that in the overall treatment paradigm.
Thank you. Another question, again on drug treatment. The participant noticed in the first lecture that the slide with non-hormonal options, well, he called tibolone non-hormonal, which I think is wrong, but fezolinetant was included. What does that mean? Are these safe in women with cancer? So it refers to fezolinetant, not to tibolone. Yeah.
So that is, the brand name is Veozah, and it is a new medication that approved in the US. It is working through a different mechanism through the KNDy neurons, and it is a non-hormonal. So although it hasn't been extensively studied in the cancer population, I can say from, personal use as well as discussion with other experts nationally and internationally that have had experience with this. It does work, it's safe, it's an effective. The big issue is you need to monitor for liver issues. Very rare, but it is a warning and precaution. It can't be used in patients who have cirrhosis. And in cancer patients, remember that they are undergoing chemotherapy, so they may have abnormal AST, ALT, or bilirubin. The product label indicates you must get baseline normal labs and then repeat them every 3 months. So it may be a little bit cumbersome. I have my patients only get a 3-month supply. They're instructed at 2.5 months to get labs. And they're actually quite compliant because the medication works quite well, and it can work in as early as 9 days. And it's remarkable. They have emerging data on sleep as well,
Yeah.
which we know is so critical.
Yeah.
So it is 45 milligrams, and it's taken once daily, but it works through the KNDy neurons centrally, and has been shown quite effective, although not formally studied in gynecological patients, but no warnings or precautions or contraindications,
Right.
just assessed.
And there is another question now to Sheryl. What is the role of HRT in patients with vaginal stenosis, with cancer patients in relation to maintaining sexual function?
Well, I'm
Yeah.
not sure that goes to me or to Michael, but again, it depends on whether it's contraindicated. But certainly, vaginal hormone therapy makes a lot of sense if they are able, because you're already going to be at risk for GSM, and you need those hormones vaginally to try and keep as much sexual health. But it still may not be enough with pelvic floor radiation.
Right, because I think this is probably in the context of cervical carcinoma or other carcinomas which are not hormone related. So I think it should not be really a problem in my view, depending on the
Can I also add, though,
Yeah.
regardless, because Dr. Krychman was talking about using dilators, pelvic floor physical therapy is amazing, but even when you treat pain and the pain is gone, there is an anxiety, right, that occurs. And so sometimes either psychotherapy or treating the vaginismus with psychotherapy and dilators can be really helpful to help women learn how to appropriately use and not experience pain. There are recent studies that really point to the fact that women, healthy women, young women, are having sex with pain and just living through it. And so we need to change that education as well, that women should not have to have penetration with pain.
Okay. Very good. Now, the very last question to Sheryl, which is completely difficult. The participants, Dr. Kingsberg, thank you very much for your talk. My question to you is, what approach would you suggest to a couple that struggles with intimacy after intensive breast cancer treatment and a demanding partner with autism? She has body image issues after total mastectomy and genital pain. He wants his weekly share of penetrative sex. Thank you very much for that question. Please.
Oh, you had to add in that he has autism. I assume it's a male partner, and that's where the penetrative sex comes in. Well, I would refer them to a sex therapist or a mental health professional who is used to having those conversations, because it really even without the autism spectrum addition, I'm telling you, most men need that slow, steady education anyway. So, don't assume that if they're not struggling on that spectrum, that they also don't need that education. They do. And it really is about explaining, the process, and that there is a goal at the end. And if they don't work with the partner to help to have non-penetrative, pain-free sex at first while she is going through her rehabilitation, then they go one step forward, 5 steps back. So educating him, if it's a him, on why this process will make a huge difference. You have to engage him in the treatment as a support, and help him recognize there are other ways that he can have his, did you say weekly, daily, whatever it is, sexual encounter. And sometimes that is educating all couples that penetrative sex is but one way to engage in and enjoy sexual activity.
Right. I don't know whether we still have time, but there is another question coming in, and I think that's for Michael, what is the role of reconstructive surgery in vaginal stenosis atresia? How much is it successful? I don't quite understand. Okay, please. Reconstructive surgery in vaginal stenosis.
So I think this is the discussion about a neovagina after a pelvic extent or extensive surgery. And these are very, very extensive surgeries, a lot of complications. And again, remember that anytime you do extensive surgery on tissue that's been compromised, when I say either usually by radiation, the cure rate and healing rate is fraught with complications and breakdown, what have you. It would really depend on the underlying issues. So I think for vaginal stenosis, we really need to do an aggressive vaginal rehabilitation, revive, restore, replenish those tissues in advance of starting any kind of dilator program. So you have to get the tissues elastic and really, hydrated well, either with vaginal moisturizer or lubricant or hormonal therapy. Very often it's an aggressive treatment. And then once that is done, really start very, very small and try to stretch those tissues as well. I think it's the last resort. And would be age dependent, it would be cancer dependent, pre-existing treatment dependent. So there's certainly a lot of variables that you need to take into consideration prior to recommending that as well.
Now, thank you very much to both of you, because I think we had this wonderful biopsychosocial approach regarding the contributing factors to sexual problem, regarding the diagnosis, and regarding the help, the therapies. Thanks very much again. And I am sure that our participants have learned a lot. I have learned a lot. We have answered all the questions that have come in. I don't know whether there are other questions you could send in, and we would try to respond to. This is the final slide, yes. This is this wonderful Congress, a little bit far from many of the places, which is in Melbourne in this year from 19 to 22nd of October. And I think you realize that there are so many fascinating topics in menopausal medicine that you should not miss it. Thank you very much, and have a good day or night wherever you are. Thank you.